Welcome to today's Explainer, where we're running an integrative clinical simulation. We are jumping right into the clinical material today because mastering biliary tract pathologies, well, that is an absolute requirement for top percentile board performance and elite clinical practice. Our goal here is targeting a perfect score level of comprehension on the cholestatic spectrum. Let's get right into it. Our mandate for this explainer is a rapid-fire clinical rounds approach. We're keeping a strict, peer-to-peer professional tone as we detail the intricate mechanisms, discrete management steps, and diagnostic traps across the cholestatic spectrum. Okay, we're kicking off our first module by looking at the intrahepatic target, primary biliary cholangitis, or PBC. This is an insidious autoimmune destruction that is strictly localized to the small intrahepatic bile ducts. The demographic profile here overwhelmingly features middle-aged women. Now, the earliest and honestly most debilitating symptom is often severe intractable pruritus. This itching can literally precede frank jaundice by years, usually right alongside profound fatigue. On a physical exam, you might even spot xanthelasma, those cholesterol deposits on the eyelids, and that's a direct result of severe hypercholesterolemia secondary to the cholestasis. Oh, and a quick historical note. This was formerly called primary biliary cirrhosis, but the name was officially changed. Why? Because patients diagnosed early today rarely actually progress to cirrhosis, all thanks to modern therapy. Now, we absolutely have to draw a hard comparative line here. Both PBC and primary sclerosing cholangitis, PSC, present with cholestatic enzyme elevations and pruritus, but look at the clinical variants on this table. PBC targets middle-aged women, strictly involves intrahepatic ducts, and is marked by anti-mitochondrial antibodies. PSC, conversely, affects young men heavily associated with ulcerative colitis. It targets both intra- and extrahepatic ducts, creating that classic beaded appearance you see on a cholangiogram, and it's highly associated with PANCA. So, let's test this with our first integrated assessment. We have a 45-year-old female presenting with severe itching, fatigue, and a markedly elevated alkaline phosphatase of 650 units per liter. Crucially, her AST and ALT are completely normal. Let me repeat that. Completely normal. This is the exact detail that traps lesser-prepared test takers who see liver enzymes and immediately jump to hepatocellular damage. A right upper quadrant ultrasound shows no extrahepatic dilation. The clinical picture is classic. So, which autoantibody is required to confirm the diagnosis? Let's systematically dismantle the distractors here. Option 1, ANA, and Option 2, anti-smooth muscle antibody, well, those are signatures of autoimmune hepatitis. Actually, Option 2 is a classic trap for anyone who just memorizes autoimmune liver disease without distinguishing the cholestatic versus hepatocellular pattern. A hepatocellular pattern would present with markedly elevated transaminases, not an isolated high alk-phos. Option 4, PANCA, points to PSC, which doesn't fit our middle-aged female demographic at all. And Option 5, anti-TTG, is for celiac disease. So the crucial point we are left with is Option 3. The anti-mitochondrial antibody, or AMA, is the absolute diagnostic signature for PBC. Once confirmed, this strictly mandates the immediate initiation of ursodeoxycholic acid to delay biliary injury. Just keep in mind that a definitive cure requires an orthotopic liver transplant. Moving into our second module, we shift away from autoimmune destruction and focus on the mechanics of obstructive stasis. Take a look at this ultrasound demonstrating a hyperechoic gallstone with prominent posterior shadowing. A mechanical obstruction like this in the common bile duct sets it completely lethal stage. The stasis of biliary fluid creates the perfect culture medium, driving an incredibly aggressive ascending bacterial infection, typically your E. coli or Klebsiella, moving retrograde straight from the duodenum. We must accurately map out this catastrophic hemodynamic collapse. It starts quietly at 0 hours with that mechanical biliary stasis. By 24 hours, bacterial proliferation is aggressive and entirely unchecked. At 48 hours, the patient deteriorates, presenting with Charcot's triad, fever, right upper quadrant pain, and jaundice. If left untreated, by 72 hours, the infection violently breaches systemic circulation, resulting in Reynolds pentad. This is Charcot's triad rapidly compounded by altered mental status and profound hypotensive shock. Let's be clear. This is an absolute surgical emergency with astronomical mortality. Confronted with ascending cholangitis, you must isolate the absolute management sequence. Step 1 is immediate fluid resuscitation to combat hypotensive shock. Step 2 is the initiation of broad-spectrum IV antibiotics targeting enteric gram-negatives. But listen, steps 1 and 2 are strictly insufficient on their own. The patient strictly requires step 3, emergent biliary decompression via ERCP. You absolutely must achieve definitive source control by physically removing the obstruction and draining the infected bile. There's no working around this. Let's look at a clinical variance box to ensure total diagnostic precision. Acute cholecystitis and ascending cholangitis both present with fever and right upper quadrant pain. However, acute cholecystitis is an isolated cystic duct obstruction. It features a positive Murphy sign, but importantly, it has normal bilirubin and ALK phos levels because the main biliary tree remains patent. Ascending cholangitis involves the common bile duct, which results in severe jaundice, markedly elevated cholestatic labs, and rapid hemodynamic instability. This right here, this is the exact patient that gets you out of bed at 3 a.m. for an emergent GI consult. Here is our second integrated assessment. A patient presents with a temperature of 103 degrees Fahrenheit, severe icterus, new onset confusion, and a blood pressure of 85/50 millimeters of mercury. You should immediately recognize Reynolds pentad staring you in the face. What is the absolute most appropriate next step in management for this patient?
Let's systematically eliminate the insufficient therapies. Option 1, percutaneous cholecystostomy. Drains the gallbladder, not the common bile duct. That's used for critically ill patients with acalculous cholecystitis. Option 2, isolated antibiotics. And Option 5, observation with fluids, completely fail to provide source control. Option 4, laparoscopic cholecystectomy, does not rapidly decompress the infected biliary tree and is frankly too dangerous in a patient already in septic shock. Therefore, Option 3, emergent biliary decompression via ERCP, is the only correct answer. It is the definitive, life-saving intervention.
Let's see how this builds into our third module, neoplastic kinetics. Cholangiocarcinoma is a highly lethal adenocarcinoma arising directly from the epithelial cells of the biliary tree. Specifically, you must recognize the Klatskin tumor. This is a very specific cholangiocarcinoma that localizes precisely at the bifurcation of the right and left hepatic ducts. Now, the biliary epithelium doesn't just undergo malignant transformation randomly. You must memorize the triad of distinct risk factors that set the stage for cholangiocarcinoma. The first is a history of primary sclerosing cholangitis, which, as we discussed earlier, affects both the intra- and extrahepatic ducts. The second is fibropolycystic liver disease. And the third is exposure to endemic liver fluke infections, specifically Clonorchis sinensis, which is often seen in specific global travel or immigration histories.
Differentiating biliary malignancies on diagnostic imaging requires pinpointing the exact anatomic divergence. Honestly, think of it like solving a plumbing mystery. A proximal cholangiocarcinoma, like a Klatskin tumor, creates massive intrahepatic biliary dilation. But because the block is high up, the extrahepatic common bile duct below it is completely collapsed and remains a normal caliber. Contrast this with the pancreatic head adenocarcinoma. A distal pancreatic mass compresses the very end of the common bile duct, which backs up the entire system. This leads to massive intrahepatic and extrahepatic dilation, and classically, a palpable, non-tender enlarged gallbladder, famously known as Courvoisier's sign.
24. That is the grim 24% upper limit of the 5-year survival rate for localized cholangiocarcinoma. It is a highly lethal malignancy. To put that into perspective, these patients often present late with painless jaundice, profound weight loss, and markedly elevated tumor markers, specifically CA19-9 and CEA. And this brings us to our final integrated assessment. We have a patient with a known history of primary sclerosing cholangitis who presents with painless jaundice, significant weight loss, and a markedly elevated CA19-9 level. An ultrasound is performed revealing massive intrahepatic dilation, but the extrahepatic common bile duct is completely collapsed. Based on these exact imaging signatures, we must definitively determine the diagnosis.
Let's break down these final 5 options. Option 1, cholelocholithiasis, typically presents with pain and wouldn't cause a collapsed extrahepatic duct if the stone is distal, nor does it cause massive weight loss. Option 3, PBC is an autoimmune disease, not a mass lesion. Option 5, HCC arises from hepatocytes, not the biliary tree. So now we're distinguishing between option 2 and 4. A pancreatic head adenocarcinoma would dilate the entire system, including the extrahepatic duct. The collapsed common bile duct paired with massive intrahepatic dilation, especially in a patient with a history of PSC, mathematically isolates option 4, the Klatskin tumor, as the definitive diagnosis.
We've traversed from insidious autoimmune ductal destruction to catastrophic bacterial sepsis, and finally to highly lethal neoplastic strictures. I'll leave you with this final provocative thought to take away from this simulation.
When facing the cholestatic spectrum on the wards or on the boards, do you understand exactly where the intrahepatic obstruction ends and the lethal extrahepatic collapse begins? Master these pathophysiologic boundaries, and your clinical acumen will be absolutely unmatched. Keep reviewing these parameters, and I will see you in the next explainer.